Hi guys, today we are here to talk to you about the neck injury, and that's what we are going to do. Okay, now when we talk about the neck injury, what we need to understand is that there is something which is called the penetrating neck injury, and there's something which is called the blunt neck injury. So, what determines and what tells you that what you're dealing with the patients with penetrating neck injury? So what determines that? So if at all you have like the whatever the gunshot or let's say the stab injury has penetrated deeper to the platysma muscle, that is what it tells you that you have gone deeper to the platysma. What are you dealing with? You're dealing with the penetrating neck injury. So penetrating neck injury, what is the structure which decides whether you are having a penetrating neck injury or not? The answer is breach of platysma. Okay, if you go deeper to the platysma, then you say that you're dealing with a penetrating neck injury. Very, very important. Okay. Now, let's start with this particular MCQ. Which zone of the neck is the most commonly injured in the penetrating neck injury? So, can you please try to answer it? We'll talk about the zones of the neck in a bit, but which zone of the neck is most commonly injured in the penetrating neck injury? The answer is zone 2. The zone 2 is the one which is most commonly injured in the penetrating neck injury. Now let's have a look at the zones of the neck. Okay, so how many zones of the neck are there? There are three zones of the neck. One is starting from the suprasternal notch to the cricoid cartilage. So suprasternal notch to the cricoid cartilage, that is one. Second is from the cricoid cartilage to the angle of mandible, that is two. And the third one is from the angle of mandible to the base of the skull. Okay, so there are three zones of neck injury, three zones of neck, which is from the suprasternal notch to the cricoid cartilage, from the cricoid cartilage to the angle of mandible, and from the angle of mandible to the base of the skull. So these are the three zones of neck. Now, what you need to understand is that what are the structures which are lying in these particular zones. So if you're talking about the zone one, it is the thoracic inlet, right? So the thoracic inlet to the cartilage, what are the important structure which are lying over here? So we have large vascular structures. For example, your carotids, your the subclavians, all those particular things are basically lying in this particular zone. Then trachea and the esophagus. Trachea and the esophagus and the important major vasculatures. These are the things which are lying in the zone one. What about the zone two? So this is the most surgically accessible zone, but here we have is the carotids and the vertebral artery and the jugular vein. That's there. But the zone two is very much surgically approachable. And then what we have is zone three. What is the zone three? Between the base of the like angle of mandible to the base of the skull. So here it is very, very difficult to access. It's not that easy to kind of do any surgery in this zone three. Okay. Now, what you need to understand is that further. Okay. So these are the few one-liners which you should remember, which might help you in your kind of need assess. So the thing is that which is the zone of the neck which is most commonly injured? So most commonly injured zone of the neck is the zone 2. Okay. So the zone 2 is the one which is most commonly injured. Surgically, which zone is most accessible? It is zone 2. Okay. So the most commonly injured zone is the zone 2. The surgically most accessible zone is again the zone 2. Surgically least available zone is zone 3. So it's very difficult to perform in this particular zone 3 between the angle of mandible and the base of the skull. It's very, very difficult to perform surgery, right? So, okay, so just remember this. And which is the zone which is associated with the maximum mortality? Okay, so if at all there is an injury in the zone 1, all the important vasculatures were there, then we had trachea, we had the esophagus. So if at all we have an injury in the zone 1, it is the one which is associated with the maximum mortality. Okay, so most commonly injured zone is zone 2, most surgically accessible is the zone 2, least available zone is the zone 3, and the one which is associated with the maximum mortality is the zone 1. Okay, right. Now let's talk about this soft signs of the neck injury and the hard signs of the neck injury. What do you understand by soft sign of a neck injury? Okay, so signs and symptoms, they're basically going to tell you whether the neck injury has occurred or not. Okay, so what do you understand with the soft signs? Soft signs basically tell you that, what, yes, injury has occurred, no doubt, but it is not very severe or it is not kind of a major injury which needs an emergency intervention. So that is what is a soft sign. Okay, I mean, I'm not trying to say that it doesn't need any emergency intervention, but it needs some what you call as further evaluation. Are you understanding? I'll talk to you about that. Okay. For example, hemoptysis, blood coming out. Okay, that's fine. Or oropharyngeal bleed, then you have dyspnea, then you have dysphonia, dysphagia, subcutaneous, and the mediastinal air is kind of there. Chest tube with the air leak is there, non-expanding hematoma or focal neurological deficit. So all these particular things are there. They are definitely serious, right? Obviously, you'll have to investigate them more. You have to figure out what is the problem, and then you'll have to kind of perform that particular surgery. But when you look at the hard signs, so what are the hard signs? Expanding hematoma, severe active bleeding, shock not responding to the fluids, decreased or absent radial pulse, vascular bruit or thrill, cerebral ischemia or the airway obstruction. So these are the things where you do not have even time to investigate. Why I'm kind of stressing on these hard signs, you'll get to know in a couple of minutes. But I hope you have understood that if at all we are dealing with any of these particular hard signs, we do not have time to investigate this particular patient. So when we talk about the neck injury patients, we divide the what you call as signs and symptoms into either the soft signs or hard signs. So what are the soft signs? Soft signs are hemoptysis, oropharyngeal bleed, dyspnea, dysphonia, dysphagia, subcutaneous or the mediastinal layer, chest tube air leak, then we have non-expanding hematoma, we have focal neurological deficits. So all these are the soft signs of the neck injury. Then we have a hard signs of the neck injury. In this, what we had this expanding hematoma, severe acute active bleeding, shock non-responding to the fluids, decreased or an absent radial pulse, vascular bruit or thill, cerebral ischemia, and the airway obstruction. Okay, so these are the hard signs. Now, based on that, what we need to understand is this management protocol. So what we have is, this is what is the management protocol of your neck injury. Okay, so we are talking about the penetrating neck injury. What is the management protocol for that? So if at all, let's say the patient is hemodynamically unstable, okay, hemodynamically unstable or there is an uncontrolled bleeding, okay, hemodynamically unstable patient, uncontrolled bleeding, like in other words, we have the hard sign of that particular neck injury. In that particular scenario, do you need any other investigation? We don't need any other investigation. So what we need is we directly need to take the patients for an exploratory lab, like exploration of that particular neck. So if at all we are having any of the hard signs or if at all the patient is hemodynamically unstable, we do not need any investigation. What we need to do is we need to take the patients for operative intervention immediately, operation and exploration of that particular neck. But if at all, let's say we are dealing with hemodynamically stable patients, okay, if at all we are dealing with the hemodynamically stable patients, but the patients are symptomatic. Now, what do you understand by the symptomatic? Symptomatic basically means that there are soft signs. Okay, so soft signs are basically present over here. So in this particular scenario, what you have to do, you have to kind of get this particular evaluation done of this particular patient. So in the zone one, what was there? We had trachea and the esophagus. So if at all the patient is hemodynamically stable but the symptomatic, then what we do is we divide this into like we do the zone wise kind of investigation. So in the zone one, if at all the injury is basically involving the zone one, what would you like to do? Would you like to do a CT of the neck and chest? Yes, obviously, because I told you that important vasculatures are there in the zone one. So yes, we will want to do the CT scan of the neck and chest of the patient. Okay. Then would you like to do an esophagogram? Well, yes, there was also esophagus which was present in the zone one. So it is good idea to get an esophagogram and the bronchoscopy. So if at all there is an injury in the zone one, what we basically prefer to do is CT angiography, esophagogram, and the bronchoscopy. Okay, all these things you do, and if at all they come out to be positive, then we take the patients for an operative exploration. I understand my point. So in the zone one, if at all there is an injury in the zone one, we do a CT angiography, we do an esophagogram, bronchoscopy, and if at all this is kind of all positive, then we take the patients for an operative exploration. Okay, right. What about the zone two? If at all there is an injury to the zone two, what does it mean? That you don't need any other investigation to be done, okay? Because this is the most surgically, what you call as accessible zone, and the patients are having symptoms, mean definitely there is some other other injury. So let's go and operate on that particular patient, okay? So that is what you need to understand. We are going to go and operate on that particular patient, and we are trying to see what the injury is, from where the bleeding is coming, and then we try to kind of manage that. What about the zone three? I told you about the zone 3 that is the least surgically accessible zone. Okay. So as a